Again, I would like to keep my time to as less as possible so that we can compensate and be on time. The epicardial coronary artery dissection, which is not associated with atherosclerosis or trauma and which is not iatrogenic, is called spontaneous coronary artery dissection. Typically, it's also called a SCAD, happens in middle-aged women with few traditional cardiovascular risk factors. They comprise about 80 to 90% of the patients with spontaneous coronary artery dissections. Mean age of presentation is between 40 to 50. The two comorbidities that have been associated are hypertension and hyperlipidemia. When you look at the distribution of the vasculature, left anterior descending artery is affected in about 30 to 45% of the patients. LAD, diagonal and septal together in about 45 to 61%. Circumflex, ramus, OM 15 to 45%. Right coronary artery, PDA, PLV in about 10 to 40%. Left main, very rare, just 4%. Multivessel, again rare, 9 to 23%. When you look at the acute coronary syndrome, SCAD is attributed cause in about 0.4% of the patients. I think we are underdiagnosing when we look at the incidence at this point in time. So what is the pathophysiology of this? You can see diagrammatically here, spontaneous development of hematoma within the tunica media, that's the outer 1/3 of the vessel wall. Okay, so you can see here, spontaneous development of hematoma within the tunica media, that's outer 1/3, and then separation of the intima or intima medial complex, and eventually compression of true lumen causing either ischemia or acute myocardial infarction. What it says is, most of us attribute dissection to from inside out mechanism. That means there is a breach in the intima through which the blood from the true lumen enters between the intima and media and then starts spreading. But in a spontaneous coronary artery dissection, it seems to be the other way around. Hypothesis is called, it's not really inside out but outside in at this point in time. But eventually it can also break in and re-enter, leading to dissection flaps with true false to true connections. When you look at the pathophysiology, outside in is the most favored. You can see this normal vessel. You can see the adventitia, media and intima here. When there's a dissection, actually spontaneous dissection, the blood starts accumulating between the intima and media, which progressively compresses on the true lumen, and at times it can break in and cause flaps. Intramural hematoma precedes the development of intimal dissection. OCT clearly demonstrates false lumen in pressurizing the true lumen, and there could be fenestrations arising from rupture of false lumen into the true lumen. I'll show you some of the images. When you look at the histopathology, you can see that actually the true lumen is so compressed due to the blood hematoma in the false lumen. You can also see here. Periadventitial mixed inflammatory infiltrate is one of the initiating factors, which explains the mechanism to be outside in, predominance of eosinophils. When you look at the genetics at this point in time, commonest is associated Marfan syndrome, Loeys-Dietz and Ehlers-Danlos, attributed to about only 5 to 9% cases. Overrepresentation of SCAD in women, primarily due to autosomal susceptibility gene, sex-specific genes with estrogen response elements, intrinsic genes independent of coronary biology in women. You can see here, in some of them, there is a multivasculature involvement. There is one in coronary, one in the iliac, and also in the cerebral vasculature. This can happen. SCAD and sex hormones, it's something very important to understand. It's unknown whether it is the absolute level or the fluctuations in the circulating estrogen and progesterone that affect the process. SCAD reported to occur before or during menstruation while on OCPs, hormone replacement therapy, treatment for infertility. Mechanism needed to be elucidated at this point in time, can occur anytime during or after pregnancy. 70% occur postpartum within the first week. Many of them may present as Takotsubo or acute dysfunction, LV dysfunction. Postpartum SCAD, more severe clinical presentation, impaired LV function, cardiogenic shock, left main or multi-vessel dissections. 5 to 7% of the SCAD cases are attributed to postpartum. Both postpartum as well as non-postpartum SCAD patients more frequently multiparous, higher prevalence of prior infertility treatment or preeclampsia. So what are the precipitating factors? It's quite a combination. Emotional stress, medications or drugs during pregnancy and hypertension, intense exercise, and Valsalva-like straining can cause spontaneous coronary artery dissection either due to fibromuscular dysplasia and associated arteriopathies, connective tissue disorder, inherited arteriopathy, susceptibility gene, pregnancy, hypertension, migraine and other. This is a very varied combination of factors. Emotional stress more common in women, physical stress more, especially when they're exercising or vomiting, retching, cocaine exposure, cancer treatment, which makes the the vasculature more friable. Clinical presentation similar to that of atherosclerotic ACS. Angina or equivalents are present in about 26 to 80% of the people. NSTMI can be there in about 13 to 69%. In about 3 to 11 it could be ventricular arrhythmias, cardiogenic shock, sudden cardiac arrest, much less frequent. Incidence of iatrogenic catheter induced, we know it could be 3.4% to less than 0.2. Coming to the classification of spontaneous coronary artery disease. One is called type 1, where there is multiple radiolucent lumens. That means it starts in the media, then breaks into the lumen. You can see multiple layers. Type 2 and 3 are where it is contained within the media and compressing the true lumen. There is no connection between the intramural hematoma and the true lumen. It just goes on compressing. What is important is in type 2, it's a long, diffuse and smooth narrowing. Many of them can be considered just as an coronary artery disease. Type 3 is focal tubular stenosis. If I have to put it in pictures, you can see here, there are multiple dissections here in this wall you can make out. This is type 2 where it is contained within the media but causing compression on the true lumen. This is very focal. Fewer than 1/3, that is type 1, 1/3 of the angiographic views can be identified. Low risk for coronary progression. That means when you have something like this, very low risk of progression. The other two are not good, better to be treated. So best thing to visualize is an IVUS or OCT. You can see the true lumen and the false lumen. This is in type 2 SCAD. Many of them, when you just do an angiogram, you may think it's atherosclerosis and you would treat it. But only thing you should be mindful that the hematoma can progress further down. When you do an IVUS, you can see the true lumen and the false lumen. OCT shows with great interest. In interest of time, let me go faster. Advantage of deep penetration IVUS, but with OCT you have much more clarity. Associated risk factors, as I said, is the hypertension and dyslipidemia in these people. When you look at the causes of ambiguous, we do not completely understand, but they are associated with these. When you look at this gentleman presented with a case, this is how the right coronary artery looks. When you do an OCT, you can very well visualize the lotus stem appearance where there are multiple layers. You can start appreciating, I think, now as it comes in. Sorry, it's taking a while. Yes, you can start seeing here lotus stem appearance. It's type 1 SCAD. Since it was in an acute coronary syndrome, it was treated. PCI was done. We'll show another LED. Sorry, it's got mixed up. Here there's a right coronary artery, which was, this is how it looked, and eventually treated with a stent. They also had both left and the right in 2 arteries he had. This was also again a SCAD, although it looks like an iatrogenic, but when you look it through the OCT, okay. Coming to the, what I need to tell you in the end is when you do a PCI to these patients, you will only look at about type 2 and 3. Type 1, most of the time we try and manage medically unless there is inducible ischemia. What you need to make sure is you cover from the healthy segment to the healthy segment with considering there could be extension of intramural hematoma. I think, thank you. In the interest of time, I'll stop here.